Well, thank you everyone for your patience. We'll get started now. Again, I want to welcome everyone to the joint ATS Clinical Practice Committee webinar on the coding and billing payment rules for 2025. We have an August panel of experts to share with you some of the highlights of the final rules, and we'll also have a question and answer session at the end. With no further ado, I'd like to turn over to Dr. Omar Hussein, who is the co-chair of the joint ATS Clinical Practice Committee and a member of the AMA RUC Committee. Dr. Hussein, slides are yours.
Thanks, Gary. Everyone, welcome. Thanks for joining us for our annual update on the CMS Medicare final rule and how it's affecting our societies, pulmonary, critical care, and sleep. I've been tasked with updating all of us on telehealth, something which affects not just our society, but almost every other medical society across the country. So I think I'll lead off with just a little bit of orientation on what is telehealth. It's a word used kind of interchangeably with perhaps telemedicine, but in terms of what we're talking about today, it's unique, it's different. One way I think about telehealth, it's something which ordinarily is done in person, which for whatever reason is being done either with synchronous audio video or synchronous audio. So hopefully that's kind of clear. So everything else that's ordinarily not done in person is not considered telehealth. All the other remote monitoring tests that we do or other kind of encounters that we have with patients that aren't ordinarily done in person, that's kind of the vernacular is telemedicine, perhaps for those. So maybe one way to look at it is telehealth is maybe a subset within telemedicine. If my co-presenters, Laura, Amy, Katina, or our consultant, Denise, on the phone have any other better ways to think about it, it'd be great to hear. But for next few minutes, we're going to talk a little bit about the update in telehealth. All right, so next slide, Gary. All right, so the one we're talking about today is true for another 2 months. Okay, so it's unclear what's going to happen after March 31st. So in a nutshell, things have not changed right now compared to what we were doing last year, meaning Medicare patients can still receive telehealth services in their home. If you remember pre-COVID, pre-public health emergency rules, those rules were suspended for the PHE, and we're still living under maybe not that emergency, but living under the same rubric of rules, and that set of rules is still allowed to persist by Congress until the end of March. So that means no geographic restrictions for originating site, meaning where is the patient? The patient had to be in a certain place prior to the pandemic, at a clinic or those kind of things, or a rural area or a federally a healthcare area which was underserved. And telehealth services can be provided by all eligible Medicare providers. Before, perhaps there was one set of rules for behavioral health visits, another set of rules for non-behavioral health, but still, all eligible Medicare providers are allowed to, from now until the end of March, live by the same rules. Next slide, Gary. So the services, there's one thing that's good to know as good news, perhaps, is that the audio-only communications platform can be delivered through 31st, and also it's going to be permanently bundled into the rules that apply for two-way real-time for any telehealth service. So basically, interactive communications now permanently includes you talking to your patient through the phone only if the patient either cannot or does not want to participate in a video visit. This also means good, I didn't have in the slide, but I probably should have, is that the codes that we used to use for the telephone visits, the CPT codes, have been deleted. And now it's time for us to use the modifier plus the E&M that you'd normally use for that phone visit. So if you have questions about that, we can answer them later, but the three CPT codes that we used to use, correct me if I'm wrong, my co-presenter is 99441. I'm blanking on the exact numbers, but there's three codes that we'd use for 5 to 10 minutes, and those increments above 20 or 25 minutes have been deleted, and now we use the E&M with the correct modifier, -23, I believe, for those encounters. So it's important to realize, like, all these rules for, I think it's another chance for me to talk a little bit about background. I mean, telehealth and what we do with telehealth is an act of Congress from 1997, the Social Security Act, which at that time delineated exactly what kind of encounters could be done via telehealth. It's very specific in terms of what a patient could be, what kind of setting they were in, and crossing state lines, and all those kind of things that we used to live with before the pandemic are all acts of Congress. So a little bit of just perhaps reframing or just understanding why it's happening this way is a lot of times CMS is reluctant to make rule changes which they interpret as being not in accordance with what the law was passed before in 1997 and updates in 2023 with the CARES Act, and then with perhaps other updates, going forward. Back to the slides. Great. So again, if the patient does not consent to or use video technology, the phone, the real-time audio only is okay to use. And again, this has been an issue with which ATS, CHEST, and AMA have been advocating for years to allow for treating patients who either don't have access or can't or don't consent to treat them like patients who have video also to help relieve that disparity. Sorry, next slide. While some things have been extended to March 31st, other things have been extended to the end of the year. So topics like supervising residents is now allowed to do the same way we've been doing. So direct supervision of residents when the resident provides telehealth can be done through December 31st. There we are. Frequency. So all the frequency limits that were there pre-public health emergency, those frequency limits are still lifted until the end of this calendar year. We still don't have to provide the address of where the provider is conducting the telehealth visit. And importantly, there's also now a code, which is a code change, which has occurred from G 2012 to CPT code 98016, which is the brief technology-based service. So that's kind of like the virtual check-in is what we refer to it as. That's a scenario where an established patient calls your office and says, what, I'm not sure if I need to come in. Can you just do what's called a virtual check-in? That requires the provider to do what? To review the chart. So you get a message from your office saying, hey, Ms. Smith wants to know if she needs to come in. You do a chart investigation. You look and see what recent results have come through. You talk to her. So this means that she hasn't seen you in the office for at least the past 7 days. So more than 7 days ago is the last time you saw your patient who calls for a check-in. And this check-in does not trigger you to see her in the office, him or her in the office within the next 24 hours or your next available visit. So it's basically literally like, everything is okay. You can wait till your next scheduled visit, more than 1 day from now to follow up on whatever questions you have. So for that work, we now use 98016, which gives you an RVU of 0.3. 0.3. Next slide, Gary. So important to note that while these updates have occurred to the rules, in the background, the last how many years, 4+ years now, the ATS and CHEST on behalf of society has been advocating for the creation of the E&M telehealth codes. They've been created with our involvement, and the RVU Update Committee has validated the RVU numbers associated with these 17 codes. These codes go from 98000 to 98016. They basically are kind of mirror in many ways the in-person E&M that we're all accustomed to doing. There are some differences in the RVU value that came up during evaluation process, and obviously the practice expense costs are different for a virtual visit versus an in-person visit. But with these codes, Medicare has, while they've posted the values and the CPT code, they are not adopting them for use in Medicare. So the AMA tried to have an argument that these codes should not be subject to Medicare statutory definition of telehealth that we talked about a little bit ago. What's telehealth? Telehealth is a service done via audio, video, or audio only, which ordinarily is done in person. The AMA argument was that these have been separately constructed codes and separately valued and shouldn't be confined or need approval from Congress to adopt. CMS responded differently in the final rule, saying they weren't persuaded by AMA comments. So basically the physician fee schedule services to be reported with codes for in-person should be used plus the appropriate modifier 23 or 25, depending if you're doing audio video or audio only. The other slides I have, Gary, might be close to my conclusion. Okay, a few more things to go. So after what's going to happen after March 31st, obvious kind of concern. So the originating site requirements and the geographic location restrictions might return. We're not going to know until, and CMS has left it up to Congress to act to adjust the rules they've already made regarding telehealth, going back to the Social Security Act in 1997, even perhaps adjusting the language from that. So back before, according to the 97 Act, Medicare covered telehealth only when the patient was in a rural area. Patient had to leave the home and go to a different site that had the AV equipment, a certified site almost. Telehealth was limited to patients who have pre-existing relationships, only for established patients. And the physician would have to conduct from place of practice and provide the address. So that's what is I guess scheduled to happen if nothing changes between now and March 31st. The CMS in their final rule has acknowledged all the comments that they've received regarding how much care has changed or perhaps even improved with telehealth being used across the country, but they're following their own interpretation of the Social Security Act of 1997. Next slide, Gary. I can hand off. Yes, we can hand off now to Dr. Hostek, my co-chair in the Clinical Practice Committee.
Great, thanks, Omar. And we did, just to echo what Gary said, we did leave quite a bit, hopefully a bit of time for questions, because there's not quite as much new stuff in this year's rule. So this is going to be brief for pulmonary rehab. A couple years back, we had, actually, was it 2022? We had gotten approval for new CPT codes to recognize pulmonary rehab, which led to deletion of the Medicare G code. And those two codes reflected pulmonary rehab sessions being done with or without continuous pulse oximetry. So those have remained in effect, but there have been some issues largely around the pandemic that have continued in the rules. So go ahead, next slide, Gary. So outpatient pulmonary rehab, and those are our two codes, are currently on the list of requests for permanent addition to the Medicare telehealth services list for, again, permanent use as a telehealth service. Go ahead. Right now, Medicare has not done that. They are not approved for permanent status, but they continue to be on the provisional list, which means that they are still able to be provided in this calendar year via telehealth. And essentially, we will wait to see if in the next calendar year, the next final rule, they make a shift to either permanent status or continue provisional status, or they could actually withdraw both. So virtual supervision has been another issue with pulmonary rehab, especially during the pandemic, allowing for virtual supervision through audiovisual platforms. And right now, that was during the public health emergency allowed. Go ahead, Gary. And that was defined as a supervising physician still had to be immediately available, just like you would be in person, but that availability could be through real-time, two-way interactive audiovisual platforms. So, through FaceTime or some sort of other platform such as that. However, CMS really expressed concern that this may not be sufficient to support the physician fee schedule payment on a permanent basis due to potential issues for patient safety. So they essentially sought comment on this for this year. And one of the things they were looking for was whether this might be overused, whether there might be fraud and abuse for virtual supervision. So for calendar year 25, CMS is still extending that flexibility for virtual supervision, but only through this calendar year. And we have to look at further rulemaking in the future to figure out if virtual supervision will continue to be allowed in the future. And I think that might be all I have. And Dr. Nikolakakis is up next.
All right, thank you. So my update here is to talk briefly about the conversion factor and the update and what's happened with Medicare reimbursement. Next slide, Gary. So without going too much into the weeds, what is the conversion factor? Well, it is the complex, it's dependent on a complex formula, and it determines the Medicare reimbursement rate for each RVU for every service that we provide in the Medicare physician fee schedule. So it is the dollar value that you multiply by each RVU. And what has happened to the conversion factor, unfortunately, over the last 5 years, that amount has continued to decline. And what it is currently, January 1, is that it dropped 2.83% from $33 and those 28 plus cents down to $32 and 34.65 cents. And why did this happen? Well, what happened is last year there had been a temporary increase that had been put in place by Congress, and with an expiration date at the end of the calendar year 2024, and so it expired. There also previous had been it had been included in the macro law that had been passed, a zero. It was going to stay stable, but the temporary increase expired, and I think you can hit one more, click one more time. Yeah, so we go back one, Gary. So we were hoping it was going to go up that little bit, and that was what was included in the spending bill at the end of the end of the year, which Congress did not pass, unfortunately. And so what's in the red on that last 2025 is where we're at now. So it's we're sad that this is the situation at hand. It is until the end of March where we are. ATS, CHEST, AMA, and all professional societies are lobbying hard to change this. Now, next slide. So, as I said, this is the state we're in for all professional reimbursement till the end of March. And there is support for reversing this. And apparently the AMA, hot off the press, AMA is reporting that this week there will be new legislation introduced bipartisan into the House to create a temporary fix and increase this by 2.5%. And if this passes, it would be updated for the remainder of this year. It does not, unfortunately, do changes retroactively to anything that has been posted from January 1, should this pass. And this is, as we said, it's a priority for our societies, the AMA, and we're working hard to advocate for this change. It is a non-sustainable trajectory for all physicians practicing in the country, and we will be posting any updates as we get them in all of our emails and newsletters, including the CBQ. And I think that's the end of my piece.
So thank you. So now we're going to transition over to the Visit Complexity Code G2211 and then how that has been updated for 2025. Next slide. So just a refresher, since this is still a code that I think people are not familiar with in all of their practice. So G2211 is a code that became effective January of 2024. It was intended to recognize the additional complexity that was associated with the longitudinal care of our patients. It is an add-on code in addition to your evaluation and management services, but cannot be reported when patients are in a skilled nursing facility or a nursing facility. And then the additional pay for this code is around $16. Next slide. And the way that they describe this, so the CMS code descriptor you can see here, but it's essentially the visit complexity inherent to the evaluation and management associated with services as the continuing focal point for a patient's care. And we essentially determine whether or not we are that continuing focal point. So this isn't necessarily for primary care physicians, which I think has been a belief in many groups. This can be a specialist or a PCP. Next slide. So again, per CMS, the patient-practitioner relationship is what determines whether or not we can use it, not the condition that we're treating. So if you are the continuing focal point for all of the healthcare services related to that patient, you can use this code. But it does require that that relationship be in some form of continuity over time. So these are patients with a single serious complex condition or a patient with multiple conditions that you're managing. And then the level of service that you're billing on that day doesn't matter. So you can bill it with a level 2, a level 5. And then again, this is for the physician office setting. Next slide. So a couple of examples. So you might be a patient's primary care physician. You follow them for multiple medical comorbidities, and you're seeing them for sinus congestion. You can use G2211 because you are sort of in continued responsibility for managing that patient over time, as they're recognizing the cognitive load of managing that patient and their acute issue of that sinus congestion. It can also be billed by a specialist. So if you are an infectious disease physician managing a patient with HIV, you are only managing one condition, but you can use this code if you're managing them over time. Same thing with us as pulmonologists. If I'm managing a patient with COPD, I can use this as well. So it's not restricted to professionals in a particular specialty. Next slide. So when this was implemented in 2024, CMS had originally felt that if the E&M was associated with the procedure, there was duplication of services, and so they would not allow you to use G2211 with a modifier 25. So we were actually potentially disincentivizing people from doing things like giving vaccines in their clinic visits. Next slide. So the changes, this is really what comes to what has changed in 2025. So modifier 25 is now allowed with G2211. So you can use this in the following scenarios: an annual wellness visit, a patient who's getting vaccine administration in clinic, or you're doing Medicare Part B preventive services. And the ones that we typically think about in our clinics, I will show you on the next slide here. So you're doing a visit to determine whether or not the patient is a candidate for lung cancer screening. You're ordering immunizations, you're doing smoking cessation, you're doing advanced care planning. So if you're doing these preventive services in your clinic, you can still use G2211. Next slide. So if we think about how we use this in practice, can you use it the first time you've met a patient? You can, assuming that your plan from that visit is to establish a longitudinal relationship with the patient. So you have some form of follow-up planned. And can you use it in a group practice? If you have somebody else in your group who's covering, can they bill G2211? Yes, assuming that there is a relationship, again, between the patient and that group practice. I think I've emphasized this, but I'm going to continue to emphasize it. Can it be billed by a specialist? Yes. This is not limited to just one area or just one specialty. And then for those of us in teaching hospitals, can you use G2211 if you have a resident that is billing sort of low-level E&M? If the resident's allowed to bill, then they are allowed to use G2211, assuming they have supporting documentation. Next slide. And then just a few more examples. So I have a patient I'm seeing in clinic. I'm seeing them for shortness of breath. I'm ordering a diagnostic workup. I'm scheduling follow-up visits to continue to manage this moving forward. I can use G2211. Or I have a patient who's seeing me in clinic. It's actually a visit to discuss smoking cessation. However, this established patient now has a new complaint. They're commenting on a cough. So I'm doing separate services that I'm going to bill that E&M for, in addition to the smoking cessation, and I'm going to use G2211. I see a lot of patients for lung nodules. So imagine I see a patient in my clinic. They have stable pulmonary nodules. No additional imaging is needed. I'm not scheduling subsequent visits. That patient should not have G2211 used. Or if I'm seeing a patient in clinic and I'm seeing them essentially to give them IV fluids, again, that's not a scenario where we're able to use G2211. Next slide. And then this is here as an example. This is not a requirement. So to use this code, you do not have to do any additional documentation like a dot phrase that outlines this. There are individuals within my own institution who wanted to have something in the chart. So this is just an example of a dot phrase that some individuals in our institution are using, just outlining that we're going to continue to follow this patient and coordinate their care.
And Laura, there's a question in the chat that you might want to take, or I can take. Do you see it? Basically asking, can a PCP and a specialist, and specialists all bill G2211 the same patient?
So everyone could potentially, if you have a longitudinal relationship with this patient, you can use this code. So let's imagine that they have a primary care physician who's managing their diabetes, their hypertension, their hyperlipidemia. You're seeing them for COPD, cardiology is managing them for advanced heart failure. All of those clinicians are able to use G2211, assuming that they have that longitudinal relationship with the patient.
Right. So there's no exclusion if the PCP bills it, you can't, right? Everybody, if they meet the criteria, can independently use it. And just to go back to Omar's, Denise, thank you for your comments. She was just spelling out that everyone understood public health emergency is a PHE, and the modifiers 93 and 95 are what are put on E&M codes for Medicare telehealth, 93 being the audio only and 95 being the AV telehealth visit modifier.
Thanks, Denise.
Dr. Fry, another question for you. Can the 25 modifier be used for the G2011 visit on administration of biologics?
Unfortunately, no. And so that sort of goes into the challenge of those of us who might be doing things like infusions, the biologics in clinic. I'm a transplant physician. I do a lot of electrolytes and IV fluids. I can't use it in those settings either.
Thank you. As a reminder for anyone who has questions for these experts on any topic on coding and billing, including the ones covered, please use the chat function.
One other example I'll give for pulmonary would be, if a patient comes in and has a PFT the same day as their visit, even if it's interpreted by, one of your partners and not yourself, depending on how you split up that duty, if it's done that day, that's still a 25 modifier and is excluded from use of G2211.
So again, I'll remind participants on the webinar that if you have questions, please use the chat function.
Does everyone see the question for critical care documentation? In other words, and we've heard this from a lot of people about what constitutes critically ill. In fact, we had one of the former ATS presidents tell us that her folks had told her if she could go and get a cup of coffee, the patient was not critically ill, which none of us would agree with. I don't know, Omar, you were involved in that. Do you want to speak to this, or do you want me to?
Yeah, I think we can both. I think it revolves around the idea of there being an organ dysfunction, which, if untreated, could lead to death or serious morbidity. I think is kind of how I frame it with anyone who wants the thumbnail. Again, it doesn't require to be you can go get a cup of coffee and write your note, and the patient can still have acute hypoxic failure, which could be, if untreated or unseen by a specialist, could lead to death that day. Requirement, the documentation need is probably the most straightforward for critical care than other things that we may do. It needs to reflect that area of risk for the patient, and perhaps make it clear that if untreated or unsupervised by us, bad things can happen. So it doesn't and the time that requires to achieve that. Amy, you want to talk a little bit about perhaps from last year, even the changes in the follow-up code for critical care?
Yeah. Oops, sorry. Everyone froze. Yeah, and just to add on to what it is tricky, and I see the additional comment, which I agree with, because there are plenty of times in which a patient who's in the ICU is not critically ill, and that may include times where maybe your hospital requires that you do an amiodarone drip in your ICU, but that does not necessarily mean the patient is unstable, or a patient with ALS on a home vent comes in, and the only place you can provide ventilator services is in your ICU, despite the fact that the patient is not otherwise unstable. But I would emphasize kind of what Omar said, which is the patient, may be highly acute in that moment, but I think another way to look at it would be that they are at immediate risk for life-threatening decompensation. So they may be stable in the sense of what we think is stable in the ICU, which is not stable on the floor stable, but they are at high risk of acute life-threatening decompensation. And that's the language that I often would use. And really, because that documentation other than time is to basically say why are they critically ill? And I know, and I agree, there's the mention of, it'd be nice to have some clear cut stuff, but sometimes that can actually go the other way and kind of hand tie us in terms of our interpretation of critical illness and what we think if a patient is critically ill or not. And there are definitely variations in how people are interpreting this. But I think we've pretty much held to that same definition that Omar said. And then just to update you guys, what Omar was referring to is, I think many of you are aware that now for the second year in a row, the 99212 code, the subsequent code, requires that 104 minutes have been spent before that can be billed. And essentially, we can go into the weeds about this, but it was sort of what we consider to be an error on the part of Medicare. The problem is that fixing the error is actually quite difficult, but that's actually something we've continued to push hard on. We've had many conversations with Medicare, including recently, to try to basically fix that, because really it's supposed to be the first hour of critical care that starts at 30 minutes, but would end at 74 minutes, just like other codes where you have to have met a certain amount of time beyond the time of the initial code before you can bill the next code. This sort of erroneously did that. So that's continued to be a real issue for all of us. Just be aware that we are still quite actively working on a fix to this. It's just, as you could imagine, not simple anytime we're dealing with Medicare, but we have not given up on that fight.
Dr. Hossack and Dr. Hussein, in discussing critical care, you'd alluded to the time element. Do you want to talk about specifically what the time requirements are in documentation for critical care?
You mean in terms of what you have to write? Yeah, and I think you really just have to be specific about how much time you spent, and that time historically has meant time on the unit and not necessarily time in your office writing your note if your office is in a distant location. But time, as we all know, is kind of difficult to quantify. Like you're seeing another patient, and then the consultant comes by and grabs you for 5 minutes about the patient down the hall, and then you go back to the other patient. And so, the truth is we're all estimating it, but as best you can, be specific in terms of how much time you spent. The other thing that does not count into critical care time is just general family updates. So you could spend 2 hours talking to a family, but if you're not really making decisions about goals of care and other critical decision making, it really does not count toward critical care. A couple other examples would be, I know there's been a lot of talk about, how do you bill for point of care ultrasound? And, we are not necessarily generating ultrasound reports. We are not radiologists, but we're providing that service. That is something that you can bundle into your critical care time. So if you are at the bedside doing a POCUS, that time is critical care time. And that's, because we're not billing it separately as a procedure, that can be lumped into the time that you're spending on the patient. Any examples you guys can think of that I forgot that might be relevant?
I just want to make a comment in regard to the chat question about the 4 pressors being questioned, and I remember having that discussion with coders in the past myself, and I think what we all have had the patients that, may not change, their status may not change significantly day to day. They're still on the vent, they're still on pressors, but you're not necessarily making any changes. One of the terms to avoid in your documentation may be stable, and just kind of remove that from your vocabulary altogether, and say that the patient is persistently requiring all these pressors, or consistently we're making attempts to titrate, but they just get confused with the word, thinking that stability means that you're no longer critically ill. So I think that's something to avoid. And in terms of the discussion with the family, just remember that you can use the family discussion updates if you can't have the conversation with the patient. So if the patient is sedated and can't participate in the discussion, then the discussion with the family counts towards your critical care time. If you can talk to the patient and you also talk to the family, that time does not count.
Thanks for that clarification, Katina. And I agree with you about the word stable. Just what we mean by stable as intensivists is not what they mean.
But I think it's also, as patients, or hospitals become busy, and throughput is an issue. There are patients that may physically be in the ICU and no longer be critically ill, and those patients, you should be using subsequent hospital charges on them.
So I see we have a raised hand from Howard Saft. Howard, can you use the chat box to submit your question, please?
Yeah. My preferred language in the ICU is often continues to be critically ill, requiring ... because they're stable on ECMO, but they're on ECMO.
Right. I agree, Laura. I have that same kind of verbiage too. And even after that, if I'm in a place where I get some pushback, I'll say withdrawal of ... can lead to death. So I think that's a key way to perhaps frame it in your own head. And if needed, document it that way also. Like removal of ECMO will cause death. Removal of 4 pressors can cause death. So I think it's okay to make it that plain if you're in a place that demands that or has that level of scrutiny.
Dr. Sapp, we're waiting on your question, if you got one.
Maybe he's having trouble with the chat function.
Let me see. We can rescue him and unmute him. Here we go.
Here we go.
Oh, I'm going to say what we have at in our system, and then I think others can answer at theirs, but there is an ability.
Can you read the question for people?
Thank you. So the question is that, patients and families can now see notes. Is there a way to document in a way that you're protecting the information from the family? And at least in our EMR, there is a way to hide notes. I don't use this feature often because I feel like it is important to be transparent about what we are communicating about our patients. But if you think that there is a safety concern by somebody seeing a note, you do have the ability, at least in our EMR, to hide notes. So I think it would depend on your EMR. We use Epic, and I have that feature.
Yeah, and we don't have that feature in our system we're on, Cerner, and I know even different epics have different features, but there are documentation options for like phone messages and other things that are not visible to the patient unless it is addressed to the patient, unlike labs and other notes. So there are some places you could still create something that is in the medical chart for posterity and medical legal reasons or all the reasons, but it wouldn't be immediately available to the family. But it is a struggle these days. I think we all understand that, and having families have access to their family members' portals can be great, and it can be challenging. And then we missed.
You have a question
I think
regarding,
you are kind of knowledgeable about the incident to billing and clinic. Do you see that?
Yeah, I can try to tackle that one along with anyone else. So incident to billing and clinic is what? It's like the ability for follow-up care provided by advanced practice provider to be reimbursed at the full rate. When that visit is incident to, that's where word comes from. Incident to a prior establishment of a plan. So if I'm seeing a patient, I've established the plan and the assessment, and the follow-up is incident to that initial visit. As long as I'm available in the clinic, and again, correct me if I'm wrong, others on the call, but my practice is if I'm in the clinic and an APN is seeing that patient without me even seeing the patient, but it's incident to my plan, following up on checking up on side effects or efficacy, it's documented that way and billed and then reimbursed at the rate of the physician. Any corrections for that? I kind of took it off the cuff. That's how I do it where I work.
And I see the question too about the concern for risk of patient copay. So I think you're talking about like the virtual check-ins and things like that. Oh, thanks, Kim, yeah, thanks. And I'll actually let Katina speak to this because I know Cleveland Clinic has dealt with this, because I think that this is the issue for a lot of systems is if a patient just sends you a message in the portal, do they expect to get a bill? To put it simply, right? And I think they want the flexibility, but they don't necessarily want to pay extra. And at least we're in a transition period of that becoming the norm. But Katina, I know you guys have gone through this. Do you have anything else to add?
Yeah, I haven't heard this as a complaint recently. I know there was question whether like the G2211 was going to add an additional copay, and that has not, at least it's not supposed to. If there's some payer trying to do that, I would have your financial team check into that, but that should not be happening.
I have heard of that happening with a couple of systems with G2211. And so patients are getting the charge and then they're just going back and removing it from the office visit. It's when it's being used with private payers who are then trying to shift it to the patient.
Right.
Yeah, and to that point, that last question, not to cut you off, Katina, but
Yeah.
you can build G2211 if it's appropriate. The question is, we don't always know who's reimbursing it outside of Medicare. We know Medicare is reimbursing it, but and that's where, to Laura's point, there may be private payers that are charging, even though that is not the way it is through Medicare. And some may choose not to bill it at all, and there may be regional differences in that as well. So that it's tricky. But you can bill it, and it just
You can, and we encourage people to bill it, and and then follow up with any providers that may because they may change. At the beginning of last year, there were payers that did not cover it, and by the end of the year, they seem to start to cover it. So I think this is still going to be a moving issue. Even Medicare is, they're watching obviously the utilization, and we know it's staying for this year. And I think we'll be talking about this this time next year too.
And that actually reminds me, back to telehealth, we were having a sort of conversation ahead of this webinar about the new telehealth codes. I think it's also unclear what commercial payers are paying for the new codes as opposed to just still paying for the E&M with the 93 or the 95 modifier. And I think each institution is dealing with that a little differently. We've just kept billing the E&M like we have for everybody. And part of that's because I don't necessarily know who's got what insurance at the time of the visit, or it's work to figure that out. And could be changed on the back end, but there's several, Denise had mentioned that there's several surveys that have gone out from various organizations to try to basically figure out, and Katina, you said the same thing, like,
Yeah.
are they wanting the new telehealth codes, or are they just wanting to stick with the E&M like what Medicare has decided? So I think there's still a lot of uncertainty there about what we're supposed to be using for non-Medicare patients.
One other thing, just to comment on the G2211, because these are, Medicare created the code, so it is for new and established E&M because Medicare does not accept consultation codes. So it's only for new and established in the office, and we don't submit G2211 as an add-on for any consultation codes. And then if the intent obviously is you're required to plan to see the patient again, we then would use it on the subsequent established visit.
Well, thank you for all the panelists' presentations today, and thank you for the thoughtful questions from the participants. This webinar has been recorded and will be posted on both the ATS and CHEST website in the near future. So again, I want to thank all of the panelists for the presentation today and thank the participants. And with that, we will conclude today's webinar. Thank you and have a great day all.